So Ibrutinib is frontline. It has been approved for any patient previously untreated, also relapse and 17p deleted patients. But let's talk about some of the side effects of Ibrutinib. And there are many second generation BTK inhibitors that are also being evaluated right now as well. So stay tuned for their toxicity data and some of the head-to-head with Ibrutinib will eventually be emerging. There's a concern. We know that Ibrutinib, when I talk to patients about initiating therapy with Ibrutinib, we talk about some potential short-term side effects of the drug as well as some potential continuous side effects of the drug. The most that patients and physicians are concerned about, of course, have to deal with cardiac arrhythmias, most commonly being atrial fibrillation, although they could have others, and folks who might be on anticoagulant drugs, antiplatelet agents for other reasons, whether they be cardiac reasons or other reasons. There is a concern because we know that Ibrutinib does have a slightly increased risk of bleeding as well. And so then if you add Ibrutinib to somebody who's already on an anticoagulant agent, there's a concern that enhanced bleeding or bruising, or obviously more seriously, a fatal bleed is the concern. I think that we have very good follow-up data that suggests that it's not that you cannot not use Ibrutinib with anticoagulants. I think you can. Do I think you have to be cautious? Absolutely. I think we have pretty good now follow-up data even from the phase 1 study of Ibrutinib, both in the frontline and relapse settings, showing that major risk of hemorrhage is low. On the average, depending upon the study, somewhere between 3 to 5%. The atrial fibrillation, however, or cardiac arrhythmias probably has increased because we have longer follow-up than the initial studies. Initial studies really reported somewhere about 5 to 7%, with long-term follow-up data anywhere probably now from 10 to 15%. So that is a real risk that you need to discuss with patients. And patients will, when you start discussing some of the side effects of these medications, there are some patients who will absolutely say, I am too afraid of this and I do not want that, and give me something else. And I can't say that's not unreasonable, because there are many choices now than there were ever before. But are they manageable? Yes. I mean, we used to manage a lot of side effects just with chemoimmunotherapy. And so as with newer therapies, we learn to manage the side effects with the BTK inhibitors. We're hoping that some of the newer BTK inhibitors, that their side effect profiles will be better. So they may have reduced cardiac arrhythmias and bleeding risks. Again, that remains to be seen when the data will eventually get presented, hopefully. And if so, that may be a game changer for Ibrutinib if there are other drugs that have less side effects and are equally efficacious. The other side effects that people get concerned about with Ibrutinib is hypertension. And of course, being that our patient population is older to begin with, so remember the median age of CLL is 70, 72. Many of these patients already have comorbidities, including hypertension, diabetes, and heart disease. So many of them are on the medications to help with these other medical problems, so that you do have to co-manage potentially side effects while the patient is on Ibrutinib with their internist or their cardiologist. If they're on antihypertensive medicines, they can be tweaked if their blood pressure gets higher. I think that there is a concern for folks who don't have cardiac issues and then develop atrial fibrillation, if they were never on blood thinners or blood pressure medicines, and then all of a sudden you tell them they're going to stay on them. For some individuals, if they develop atrial fibrillation, they choose not to because they really don't want to have to be on all these extra medications and all these cardiac medications. So there is no doubt with some of the toxicities that we see, you do have to have an open view with your patient to whether or not they can co-manage them, they're comfortable co-managing them, because they're all manageable. But whether or not the patients want to pursue and stay on Ibrutinib or change to another agent always does come up, and it's a frank discussion. But I don't think that if somebody is on an anticoagulant per se, Ibrutinib is not completely contraindicated. I think that we've seen plenty of folks who are on Ibrutinib and anticoagulants who are doing well, but you have to make them aware that they are at an increased risk of bleeding, and obviously to stop the agents before any surgical procedures. So there are some nuances that you have to take when somebody's on Ibrutinib and anticoagulants, or even on Ibrutinib alone, and you educate your patients. And the more familiarity I think that oncologists become with using these novel agents, the better that they will be at managing any of the side effects to any of the novel agents that are coming across our path. So I think it's just taking a little bit of time and a little bit of education and experience. And now there are going to be many options. So certainly then I think there'll be more room to pick and choose depending upon your patient's comorbidities.